Hi, good evening everyone. Let's just start it. So welcome you all to Unacademy. Okay, just 2 minutes. Yeah. Okay. So let us start with this session. But before that, let me tell you about some exciting offers going on at Unacademy. So you can get 20% subscription if you're planning to buy. Yeah. Hi Tej. Hi. If you're planning to buy a subscription, this is the right time for you. So we have a lot of revision classes going on, lot of activities going on Unacademy, and that too at a, you can say, excellent throwaway price. And apart from that, we have the Q Bank which has been upgraded, and along with that, we have a lot of new things that we have integrated. We have started a new exercise of integrated batches. So today we are going to study one very important thing, that is approach to chronic pancreatitis. Yeah. So good evening everyone. Once again, let me start with this topic of chronic pancreatitis. So when we talk about chronic pancreatitis, what is the concept of chronic pancreatitis? First of all, we have to understand. Other than acute, we have one more type of pancreatitis which is known as chronic pancreatitis. And what is that? Why is NG tube kept and urobag is connected in pancreatitis patient? I'll tell each and everything. Don't worry. But acute pancreatitis is the insult of the pancreas which leads to inflammatory activation. But sometimes this activation keeps on going, and it's just continuing for a very long time, and thus it causes permanent damage and fibrosis. So what is the concept of chronic pancreatitis? It is based on something which is known as SAPE. What do you mean by SAPE? Can I have it from the audience? What do you mean by SAPE? SAPE means love at first sight. Do you know what is love at first sight? First time when you saw that girl, and that intense, you can say, feeling that started, and that memory of that event is always there inside you. Even when she goes away from your sight, you're still thinking about her for next 1 month, 1 day, 1 year, maybe for life also. So that is what is SAPE. Sentinel means the first. So sentinel, acute pancreatitis event. So the first pancreatitis event is considered as SAPE. So acute sentinel acute pancreatitis event, and this leads to what, students? Do you know what is the heart of pancreas? We have certain cells which are known as stellate cells and myofibroblast cells. So this causes the stimulation of two very important cells, and they are the stellate cells of the pancreas. So it causes the stimulation of stellate cells, and along with that myofibroblast cells. So myofibroblast cells and stellate cells. Now what is going to happen if you stimulate the stellate cells and myofibroblast cells? Let me tell you, this is very easy. This is the memory, or you can say these are the pacemaker cells of the pancreas. They are the memory cells of the pancreas, and they capture that insult. And do you know, because of this, what happens? Even after recovery from pancreatitis, recovery from acute pancreatitis, the inflammation continues into what, students? Continues at the level of stellate cells and the myofibroblast cells. And this is what is very important. So since the inflammation cascade starts, it is going to actually perpetuate, and this leads to what? Recruitment. This leads to recruitment of inflammatory mediators. So there is recruitment of inflammatory mediators, and because of this, now what will happen, students? Because of this, one very simple thing that is going to happen is fibrosis of the pancreas. And do you know why fibrosis happens? Because of the increase in, and this was a question also, what is the agent responsible for fibrosis? Answer is fibroblast. So there is increase in fibroblast, and this is going to cause fibrosis of the pancreas. Now let us see, when there is fibrosis, therefore there is permanent atrophy. So there is permanent atrophy of the pancreas, because of these things. And this is what is very, 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 very important. Very important. Just a minute. Let us try to understand more important things. So this is how the pancreatic atrophy occurs, and because of this, there is loss of exocrine function also. So there is loss of exocrine function also, and then there is loss of endocrine function also. So loss of exocrine and loss of endocrine function. Now I'm going to discuss few important things. When there is loss of exocrine function, what are the things that you are going to get to see? Tell me. So if there is loss of exocrine function, what will you get, kids? Tell me. This is what is very, 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 very important. Let us see. So because of this, you will get to see diabetes mellitus. You'll get to see diabetes mellitus. Now what is so special about this diabetes mellitus? And because of this loss of exocrine function, what you are going to get, students? Malabsorption. And why malabsorption? Because of the loss of lipase, etc. And why this happens? Because of the steatorrhea. Because of the steatorrhea. Are you getting this? One more very important thing. I'll discuss about the special character of diabetes mellitus here also. But I will also discuss one more thing. Because of the fibrosis, there is also obstruction of the duct. So there is obstruction of main pancreatic duct. And do you know, since there is, so suppose this is the pancreas, if you take this to be the pancreas, and there is pancreatic fibrosis at this level, yeah, this is pancreatic fibrosis. So slowly and slowly, this duct will, what, students? This duct will enlarge, and this is going to result in what, students? Ductal hypertension. So because of the obstruction of main pancreatic duct, there is enlargement of the duct, and because of the enlargement of duct, what is going to happen? This is going to cause the stretching of the nerves, the stretching of retroperitoneal nerves. And since there is stretching of retroperitoneal nerves, what is going to happen, students? Because of this, you will have extreme pain. Now, who is a proof to this? Because of this complex relation, that patient is having pain because of the ductal hypertension. This is what is known as what? Ductal hypertension. We have a special term for this, that is ductal hypertension. And what is ductal hypertension? It is nothing but the obstruction of main pancreatic duct, resulting in what? The sudden stretch of the pancreatic duct, resulting in the stretching of the nerves. Now the proof to this is, whenever you have a patient with intractable pain, you can go for chemical sympathectomy of the, or you can say of the celiac plexus. So celiac plexus block helps the patient. Why? Because this is going to cut down the sensation to the nerves, and that is why the pain is relieved. Now this is what is very, very, very important part. And this is, it is only because of the pain for which the patient is visiting the consultant again and again. Now what is so special about the diabetes that you get to see? Can I have it from the audience? Now students, generally, if you talk about the diabetes, this is a special version of type 2 diabetes. Now what is the special version of type 2 diabetes? Can anyone tell me what is the special version of type 2 diabetes? This is what is very, very, very important also. A special version. Yeah. One more thing that I want to understand is, normally what happens in a conventional type 2 diabetes? In a conventional type 2 diabetes, there is development of progressive insulin resistance. Are you getting this? But here, there is progressive, in this, there is progressive decrease in insulin. And when a product is vanishing from the market, and if that product is actually important, the demand for that product is going to be elevated. Suppose today you come to know, students, that from tomorrow the iPhone will not be there and you have only 1 lakh iPhone left over the world. So definitely, if you like and love iPhone, you will definitely try to secure one for you also, for yourself also. So similarly, body comes to know that insulin is getting short of, and this message is given to all the organs. So all the organs become hypersensitive for the insulin. So because of the decrease in insulin, there is peripheral, increase peripheral end organ sensitivity. And this point is very, very, very important for all of you to understand. So there is increase in peripheral end organ sensitivity. Now, do you know in pancreatitis there will be damage of insulin also? There will be damage of there will be damage to the insulin producing beta cells. There will be also decrease in the glucagon, and there will be also decrease in pancreatic polypeptide. Now, what is the significance of this pancreatic polypeptide? Can I have this from audience? Can I have this from audience? What is the significance of this pancreatic polypeptide? So let me tell you what happens. In chronic pancreatitis, the patient has a diabetes. Are you getting? Now because of the diabetes, there is elevated what level, students? Blood sugar levels, blood glucose levels. And whenever to counter this blood sugar level, you give exogenous what, students? Insulin. So suppose you got a patient whose blood sugar levels were 240. So sister made a phone call from hospital, doctor, there the blood sugar is 250. What to do? I said give only 5 units of insulin. But try to understand, no one can gauge or no one can estimate that this is a patient of chronic pancreatitis and his insulin receptors might be oversensitive. So because of the hypersensitive what receptor, students? Insulin end organ receptors. What will happen? There is an exaggerated response, and there is an exaggerated response. So because of this, what will happen, students? The patient might land up with what? Hypoglycemia. Normally, like if you are working, you are doing an exercise, if the blood glucose levels start to fall, this message is given to the liver. And liver will start the glucogenesis. It will also start gluconeogenesis, and this is going to correct the hypoglycemia. But what happens? Who is going to tell this information? The pancreatic polypeptide is the glucose sensor of your body, and here your sensor is not working. So there is no one in fact to convey this piece of information, and that is why once the hypoglycemia develops, it develops what, students? It becomes life threatening. So can you see this kind of diabetes mellitus? This is also known as not bronze diabetes, it is also known as brittle diabetes. So if you people have not heard of this phenomena before, now you should be knowing what is this phenomena, students. It is known as brittle diabetes, or you can say type 2C diabetes. When you talk about type 2C diabetes mellitus, everyone will be knowing that this is a type 2 associated with chronic pancreatitis. So students, did you understand few important things that yeah? Again, Samir, I will repeat to you. Now, what is happening here in chronic pancreatitis? There is destruction of the endocrine function. Since there is destruction of the endocrine function, the insulin producing beta cells are lost. The glucagon production is also hampered because of the loss of alpha cells. And similarly, the delta cells, the F2 cells which are producing somatostatin, which are producing pancreatic polypeptide, everything is lost. Do you know who is the master of this ring actually? It is the pancreatic polypeptide. Now what happens? As the insulin secretion from the pancreas starts to go down, the organ starts panicking that I need insulin, and therefore there is increased peripheral end organ sensitivity. So now what happens because of peripheral end organ sensitivity? Maybe the conventional 4 unit of insulin might behave like 14 units or 40 units also in certain case. So what happens if you have a patient of diabetes mellitus and you admit that patient? What will happen? You will check the blood glucose, you will find the blood glucose to be elevated because there is decrease in insulin. In fact, there is no one to counter the rising glucose. So you exogenously give one shot of insulin, and that insulin behaved erratically by showing a hyper response to the receptors, and therefore the patient develops what, students? Hypoglycemia. So hyperglycemia lands into hypoglycemia. Normally, if a patient like me and you, if we take insulin and we go into hypoglycemia, this message will be conveyed to the liver automatically by pancreatic polypeptide, and liver will start the gluconeogenesis and glucogenesis and will correct the hypoglycemia. But now, what is the problem? The receptor, the pancreatic polypeptide, which is the glucose sensor of your body, they are not functioning. Why? Because they are also deficit. And that is why, who will convey this message to the liver that you are having hypoglycemia? And that is why they become very, very, very detrimental over the time. And this type of diabetes is very critical to handle. Why? Because on one side you have hyperglycemia. If you do anything to counter hyperglycemia, you will end up with hypoglycemia. And that is why this is known as type 2C diabetes mellitus or brittle diabetes. Kids, are these things, are these concepts clear to you? Many of you might be listening to it for the first time, but let me tell you, 90% of the people don't know how to explain this topic, and they just ruthlessly keep on describing all those things which are not actually meant. This is a beautiful topic. Pancreatitis is one of my favorite topics, right from the patient selection or from the, you can say, teaching part. Both, I love this topic. So let us try to understand what are the other things that you need to understand. So what are the risk factors for chronic? We were just discussing the concept of chronic pancreatitis. Let us talk about the risk factors of chronic pancreatitis. When you talk about the risk factors, students, we have a classical classification for them. I hope, Samir, it is clear. Yeah. So that is known as Tiger O classification. So we have a classification which is known as Tiger O classification. What is this Tiger O classification? T stands for toxins. So T stands for toxins. This is what is very, 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 very important. Then what are the other things? What are the toxins? What are the toxins that we have, students? Tell me. You can have infections. You can have hyperparathyroidism. What else you can have? You can have alcohol. Yeah. You can have the topical diet cassava. You know cassava. This is responsible for what? Topical pancreatitis. Then you can have tobacco. In fact, it is the alcohol which is one of the most prominent toxin that you get to actually see. The next is V stands for, what is I? I stands for idiopathic. Then what is this G meaning for? G is genetic. When we talk about genetic, we have one very important type of pancreatitis which is known as hereditary pancreatitis. It is caused by cationic trypsinogen gene and anionic trypsinogen gene. So we have PRES1 and we have PRES2. So when we talk about PRES1 and PRES2, they are actually responsible for hereditary pancreatitis. So it's hereditary pancreatitis, which is again very, very, very important here. Let us try to understand this. What about the other one? We have SPINK. Mutation. When you talk about SPINK mutation, what is so important here? This is for topical. This is for cystic fibrosis associated pancreatitis. Yeah, SPINK mutation. Yeah, this is. Then what else is important? Yeah, we have cationic, anionic, trypsin. There are other mutations also. This is SPINK is for topical pancreatitis. Next is. Then we have A. A stands for autoimmune pancreatitis. Then what do you mean by R? This is recurrent acute pancreatitis. So recurrent acute pancreatitis, this is more. Or you can say severe acute pancreatitis. So what is a severe acute pancreatitis? A pancreatitis which is associated with infected local complication, or you can say that it is associated with an organ failure. Just a minute, students, you have a lovely guest, because since I'm taking class from the home and she's the one who doesn't see me whole day, so she's more excited that this is my time and why is my father busy with something else. Then O stands for the factors which are going to cause obstruction. Just a minute. So, when we talk about obstruction, what are the factors which cause obstruction, students? We have stones in the pancreatic duct. Then you have pancreas deficient. So, pancreas deficient, pancreas deficient. Then we have annular pancreas. So, we have annular pancreas. So, stones, pancreas deficient, annular pancreas. What are the other things that we have? I hope you must have heard of SOD. Have you heard of SOD? Answer is sphincter of Oddi dysfunction. Sphincter of Oddi. And there is one malignancy also which is associated with chronic pancreatitis. So what is that malignancy which is also associated with? Can you tell me that malignancy? Have you heard of that IPMN, intraductal papillary? Yeah, so that is IPMN, mucinous neoplasm. Intraductal papillary mucinous neoplasm of the pancreas is associated with this obstruction. Since this is a summary based class, I'll directly go for the workup and management. So whenever you have a patient of chronic pancreatitis, how to evaluate it? The investigation of choice, it is MRI with secretin stimulation. Secretin stimulation helps to dilate the pancreatic duct, and that is why it is. So MRI with secretin stimulation, or you can go for a conventional CECT also. The CECT is also good, but yes, investigation of choices, the standard is MRI. Or you can also go for EUS. What is EUS, students? EUS stands for endoscopic ultrasound. Just a minute. Okay, let us see now. Now, what is the treatment part? Achha. Okay, then how will you confirm? Achha, there are 2-3 more things. How do you confirmation of exocrine insufficiency? So confirmation of exocrine insufficiency. So how will you confirm exocrine insufficiency? Answer is, students, fecal elastase. So fecal elastase, and then there are some urinary elastase breakdown products. When you use sodium laurate and you give it to the patient IV, and then you check the breakdown product of that sodium laurate in the urine to estimate. Yes, but a gold standard, always remember, investigation of choice is or you can say gold standard is MRI. But if you talk about the best, EUS is always considered to be the best investigation nowadays. Dekho, let me tell you what is the concept of gold standard. अन्ना के पास है अन्ना के पास माँ पूछो उससे पता करवाओ चुप. Okay, let us see. So fecal elastase or pancreolaural test. So pancreolaural test. Pancreolaural test. What is this pancreolaural test? It is estimation of fecal of elastase activity. Then how do you estimate something for endocrine insufficiency? Now this is again very important. In endocrine insufficiency, a very important thing that you have to evaluate is diabetes. So there will be decrease in insulin along with there is decrease in what? Pancreatic polypeptide. Remember, loss of pancreatic polypeptide is the hallmark feature for diagnosis of diabetes. So this is what is very, 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 very important. Now let us talk about the treatment part. It's very simple to understand the treatment of this chronic pancreatitis. Always remember, for chronic pancreatitis, the treatment of choice is always conservative. Whenever I get a patient, because mostly they are alcoholic patients, so I talk to them very decently. I ask them, how much alcohol do you consume? He said, sir, little only. I said, tell me how much. So then say the half or quarter is, sir, every day I take half or a quarter. I said, you can take the dose, or you can, whatever you were consuming, you can increase that consumption to 5 times. He said, sir, how are you talking, sir? How can I increase this consumption to 5 times? I tell them humbly that this is a patient, 5 packs if you're taking, take 10 packs, 20 packs. Tell these patients. Why? Because this is a process which has started and which will end on its own. Because the insult continues inside the myofibroblast and stellate cells. So this is an ongoing process, and until and unless your pancreas are totally destructed, you'll always have pain. So if you want to get rid of this pain, you have to get rid of the pancreas, otherwise there is no other concept. So what is this? What is the management? For the pain, the first thing that you will take is analgesics. So in analgesics, you can use a sliding scale method, NSAIDs plus opioids. And then if that is also not working, then you go for celiac plexus, you can say block. Remember, if that is also not working, then plan surgical intervention. Remember, the surgery that is done is not to cure, because pancreatitis have already been into that auto-destruction mode and you cannot cure anything. The aim of the surgical intervention is just to cure the pain part of that patient. Remember, still, this is not the criteria for straightforward hospital admission for surgery. Surgery is only done when there are multiple episodes of hospital admission because of this pain. What about exocrine function? To restore the exocrine function of the patient, one very, very, very important thing that you all have to understand is exogenous lipase. So I hope you know, Creon we have, we have Enzar, HS, there are a lot of ducts. So exogenous lipase is what we take, and we take lipase, microlipase, 15,000 to 30,000 or maybe 25,000 international units, BD with the meals. Don't forget to add the PPIs also, because if you don't, Vidya, I was also not there for a very long time, was busy with lot of things. I always missed you people, but yes, one thing that binds me and you is the motivation to teach, and you people, the motivation to study. So exogenous lipase, lipase work in an acidic environment or alkaline. It's an alkaline, but they have to be taken orally, so they go via stomach. So remember, when you tell them that you will have to take this with meals, don't forget to add what? PPIs. So PPIs, whatever you give PPIs, they are just aiming to just control the PS so that your drug should reach safely. So let us move forward now, students. Let us talk about how to control the endocrine function. For endocrine function, you have only one very, very, very simple and important thing, that is the insulin. So insulin is there. Then there is a trial going on of recombinant pancreatic polypeptide, but that's very costly and especially not available in developing countries like India. So let us go to the introduction of surgical intervention. So whenever we talk about surgery, what is the indication for surgery? Answer is multiple hospital admissions. Multiple hospital admissions for the complaint of pain. Then only you will go for surgery. Otherwise, you will not go for surgery because these patients are hyper smart. They will say, doctor, take whatever money you want, please cure this, and then you will take 3 lakhs, and then you'll do a phrase, and then he will be shouting in front of your home or of your hospital, of your clinic, that ye doctor aisa hai paisa le liya, mera dard nahi theek ho, because these patients don't know the etiology. You need to explain them this is a process of auto destruction, and now you are responsible. I am not responsible. So remember, the surgery that you do is not therapeutic. First of all, the surgery that you do is not at all therapeutic. It is what in nature, students? It is only palliative. And what is the palliation that we talk about? It is going to palliate of the pain. Are you getting this point, kids? This is what is very important. So whenever we talk about the surgery, the next thing is, what is the location of the pancreatitis? So location of the involved segment. It could be the tail. It could be the tail. That is, even though rare, very rare. So tail is a rare site, but in that case you will have to go for distal pancreatectomy. And whenever you are going for pancreatectomy, it's your choice to keep or your choice to remove the spleen. So splenectomy you can do along with that. Now if it is involving the head, because head is very important, so if it is involving the head or the body, the next thing is what to do. Now it's very important for you to understand that is there any mass over the head? If there is any mass over the head, the next thing is yes, and one is yes and one is no. If there is no mass of the head, the next thing is, are there any strictures? Or are there any stones? The answer could be yes, answer could be no. So mass is not present, there is no stricture, no duct, no stone. What to do? Now if duct is more than 6 mm dilated, this is very important. So if the duct is more, what duct, students? MPD. If the answer is no, it is not dilated, then you can go for endoscopic stenting. Simply go for endoscopic stenting. There is no objective of doing any sort of anastomosis. Now one very important thing is, if the duct is just okay. So if the duct is not dilated, then there is no point. If the duct is dilated, yes, then you are going to go for longitudinal pancreatico-jejunostomy, LPJ. Longitudinal pancreatico-jejunostomy. And this is what is also known as Pastiaus surgery. I hope you must have heard of Pastiaus surgery, or it is also known as modified Partington-Rochelle surgery. Now, if the duct is dilated and the head of the pancreas is having a mass, or there are strictures and stones, then you will have to go for then there are two procedures that we have. What are the procedures? Answer is drainage, and along with that you might have a resection. So drainage plus resection procedures are done. Now when we talk about drainage for dissections, there are two kinds. One is duodenum sacrificing. Where you can sacrifice the duodenum. So when you talk about duodenum sacrificing, what are the procedures? Can anyone tell me? But if I have to resect of the duodenum, I will simply go for pancreatico-duodenectomy. And when we talk about pancreatico-duodenectomy, what is this procedure known as? Come on. That is Whipple's. That is known as Whipple's. I'll explain it at the end. If you don't want to sacrifice the duodenum, we will have a duodenum sparing surgery. And when we talk about duodenum sparing surgery, students, the first that we have is a Frey. What is Frey's procedure, students? The Frey's procedure is LPJ plus scoring of the head mass. Scoring of head mass. What else do we have, students? The second is if it is involving the head. If it is involving the head, we can also do one more surgery which is known as Bieger surgery, where you do resection of the head, leaving a trim of pancreatic tissue near the pancreatic near the duodenal C loop, and you can bring the jejunum and do the anastomosis. And the third is burns. So phrase, Bieger and burns. Students, actually this is a summary based class, so it's not possible for me to discuss everything in detail. In routine class, I teach pancreatitis, especially chronic pancreatitis, for roughly more than 2 hours. So for that, you need to come to me and learn that. Next is, in the rare cases, if it is a small duct pancreatitis, if it is a small duct chronic pancreatitis, what is the surgery that you can do? You can do a longitudinal V-shaped coring, and along with that LPJ. What is this surgery better known as? This is known as Isbicki's surgery. So this is known as Isbicki's surgery. This is one. The second option that you can have is you can go for total pancreatectomy. So total pancreatectomy with auto-implantation, of islet cells. And where do you auto-implant? The injection of islet cells into portal vein, and this is what is very, very, very important. I hope, students, you have understood the chapter. I couldn't explain in the great depths because since this is a YouTube revision based class, you need to join an academy for better, you can say, understanding of the concepts. So I hope you enjoyed, and till then, bye bye. If you have any queries, yes, you can always tag me. You can always come to an academy, or you can ask in the class. If you are planning to join Unacademy, do use the code Dr. Dixit. So till then, bye bye. I will be connecting soon with one more same, you can say same velocity, high velocity topic for you. So till then, bye bye.